Dr. Pepe.
Yeah, and she's like 2.
She's 2.5.
A donde vivía. Su mamá estaba en Honduras y solo la tenía en Y lo triste es que a veces ni son adictos, sino que
No, hay que
experimentan una vez.
muchas veces los reporteros que están cubriendo eso no hacen la desesperación de decir eso.
Que no son drogadictos necesariamente.
Se meten en una pastilla y pues probaban de lo que sea y una cosa es que te droguen y otra cosa es que te mueras.
Test 1, 2, test 1, 2.
El mensaje es que no tienen que hacer esto ahorita porque todo está mezclado. Pero entonces lo ponen como que, como que si fuera que el niño se drogó con fentanilo.
Test, microphone. YouTube, mic check. YouTube, mic check. Test.
Give YouTube one more check.
YouTube, mic check. YouTube, mic check. Test 1, 2, 1, 2.
One more time.
Test 1, 2, test 1, 2.
She said it's a little quiet.
A little quiet. It might be the mask, that's why.
Okay.
Okay. We'll just have to let them know and speak up.
She says I can hear him say test 1, 2.
Okay, great.
Yep.
We'll get the
She said it's just a little quiet.
Just let folks know we are live on YouTube.
We have other people in other buildings check to make sure, not like our Wi-Fi to make sure they can hear
very smart.
Hear and see us.
Thanks for answering the phone. It's good for an emergency, you know that?
What are you talking about?
I called you the other day.
Hey, on Monday? On Monday?
Yeah, I called you. That's what I told you.
Yeah, that was Monday. My bad, dude. I didn't even know. You okay?
Now. When I called you for something.
Did you miss me?
No, besides that.
Hi, Sam.
Just go high over here.
Oh,
Look at that, 159.
The reporter asked me to ask you.
How are you? Nice to see you.
Hello.
You want a microphone?
Yeah, that's not supposed to look at.
Okay, there we go.
Do you have,
Yeah, just remember next time you call me.
so when you're closing this week,
Yeah, sure. That's why you picked up on Monday.
I can take a meeting for you.
I should have looked at it. Should have texted me. Well, now I gotta text you.
You want a hug?
Yeah, I might be feeling better.
Get started as soon as you all are ready. And then just to let folks know how it will go, Dr. Ferrer will do his presentation, and Dr. Singhal will speak as well too, and then I'll go ahead and facilitate questions after that as well. And we are live on YouTube as well.
Okay, great. Good afternoon, everyone. Thanks so much for being here today. We're really happy to see everyone. As always, I'll give a COVID-19 status update for LA County. My presentation will be followed by an update on monkeypox by Dr. Singhal, the Chief Medical Director for the LA County Department of Public Health. In today's presentation, I'll share our current metrics, changes in indoor masking requirements that will be in effect starting tomorrow, a look at the LA County early alert signals, a look at data from the LA Pandemic Surveillance Cohort study. This is a joint project of USC's Pandemic Research Center and the LA County Public Health Department. I will start with the first slide. Let's see if this works. As is customary, this slide tracks the trajectory of the pandemic since March of this year. The green trend line shows the 7-day average of the number of cases reported daily, and it's measured using vertical axis on the left. During the past week, an average of 1,400 cases have been reported per day. This is a decrease from the 7-day average of 1,700 cases reported per day the week before. The 7-day average for the number of daily hospital admissions are shown by the orange line, and that's measured using the vertical axis on the right. This metric has plateaued somewhat in the first half of September, but has continued to decline this past week with an average of 96 admissions per day. The blue line on this slide shows the 7-day average number of deaths reported daily, and it's measured by the axis on the right. It remains relatively unchanged, staying between 11 to 14 reported deaths per day since the beginning of the month. For those who have experienced either mild or moderate symptoms with COVID, or who know others that have, the idea that they might lose a loved one at this point, more than 2.5 years into the pandemic, seems hard to imagine. However, this is still happening to many cherished individuals, particularly among those facing the challenges of older age or illnesses that have led to more fragile health. We wish peace and recovery to the friends and families of those who have passed. We're hopeful that the new fall bivalent booster will bring greater protection for all of us. Next slide. We do continue to use the CDC's COVID-19 community levels framework to monitor the strain on our healthcare system caused by COVID-19. CDC continues to report LA County as having a low COVID-19 community level, as it's been for the past 4 weeks. As you know, the CDC framework utilizes one case rate metric and 2 hospital-related metrics. The first metric used to calculate LA County's COVID community level is the 7-day case rate, which CDC reported today at 108 weekly cases per 100,000 people. This is a decrease from 127 last Wednesday. Please note that there's still a 2-day lag in the CDC's case rate data for LA County, and our locally reported data today indicates a lower rate, which I'll talk about more on the next slide. The first of the 2 hospital metrics is a weekly total of new hospital admissions per 100,000. The CDC currently reports LA County's rate at 6.5 weekly hospital admissions per 100,000 people, and that's a decline from 8 that was reported last week. The second hospital metric is the 7-day average for the proportion of staffed inpatient beds occupied by COVID-19 patients. Today, CDC reported this metric for LA County to be almost 4%, a slight decline from 4.3% that was reported last week. Next slide. A moment ago, I mentioned that the weekly case rate that CDC reported today for LA County represents this lag. Since a weekly case rate below 100 new cases per 100,000 people triggers changes to our masking policies, I want to take a closer look at the data. On this slide, we show the locally reported weekly case rate for LA County over the past week. As you can see, it's been dropping steadily from 117 new cases per 100,000 people last week to 98 new cases per 100,000 people today. As a result, we do expect that the CDC posted weekly case rate will also drop below 100 next week. Since the California Department of Public Health has moved to reporting only once per week, and CDC uses data from the California Department of Public Health to calculate this weekly case rate, our CDC case rate now only gets updated once a week. Given how close the current CDC case rate is to 100, and the fact that we won't receive another update from CDC for an entire week, and we are reporting a county case rate of 100, we are able to move forward with the changes in indoor masking policies starting tomorrow, as we shared with you last week. Next slide. Since the release earlier this week of updated masking guidance by the California Department of Public Health, we've received several questions about the impact of these changes on the masking policies for LA County. Last week, I shared how we recently had updated the county's COVID-19 response plan to consider the impact of reduced viral transmission. We updated this plan again yesterday after reviewing the new guidance from the California Department of Public Health. I want to start by sharing the indoor masking requirements that will be in place tomorrow as we remain in a low community level and our weekly case rate has now dropped below 100 new cases per 100,000 people. As we shared last week, indoor masking requirements will remain unchanged for healthcare facilities and long-term care facilities as required by the state. Indoor masking will also still be required for those that are within 10 days of a COVID diagnosis or exposure, since this is the time when people have the greatest risk of spreading the virus to others. Individual businesses, agencies, or locations may also set their own indoor masking policy, which people are required to follow. As of tomorrow, we're shifting from requiring indoor masking on public transit and at indoor transit hubs to strongly recommending that everyone using public transit, including ride shares, wear a well-fitting, high-filtration mask. For people that have a higher risk of severe disease should they become infected, we still recommend greater caution. For people over 65, for those who are unvaccinated, for those with underlying medical conditions, and those who are immunocompromised, or living in communities with high rates of poverty, we strongly recommend masking inside settings with higher risk. Higher risk settings include any of the 3 C's: closed spaces with poor airflow, crowded places with many people nearby, and close contact settings, especially where people are talking, breathing heavily, shouting, or chanting, and they're close together. The county will align with the new state changes in the masking policies at correctional facilities and shelters, and no longer group these sites with healthcare and long-term care facilities. As of tomorrow, at correctional facilities and shelters that have not had a recent outbreak, given the lower case rate and our designation at low community level, indoor masking at these sites will be left to individual preference inside the non-clinical areas of these facilities. For all other indoor businesses and settings, indoor masking will be left to the individual preference unless the location requires masking. As we think about what these changes may mean for our masking actions, I want to share a brief plea from a rideshare driver that I received that emphasizes the need for us to continue to make decisions around when to wear a well-fitting, high-filtration mask that not just reflect our own risk, but acknowledge risk to others. This person wrote, "I am an Uber driver. I got COVID in July from a passenger who, as it turned out, I took her on a round trip to a pharmacy so she could pick up her COVID medication. I ended up with COVID. After 10 days, I tested negative. 5 days later, I had a rebound case of COVID and ended up in the hospital. After 10 days, I finally tested negative. Uber does not give sick pay. Bus drivers are put in the same position. Passengers get on buses sick with COVID. People have to work and they get on buses, taxis, Uber, and Lyft sick. Please keep masks for public transportation, buses, taxis, Uber, and Lyft. We are in close contact with passengers. Riders will not voluntarily keep masks on once you say that they don't have to wear them." I ask people to consider that perspective as they're using public transit. Strongly recommend, for our perspective, means it's a great idea to keep your mask on. Next slide. Now that we've reviewed the indoor masking guidance in effect starting tomorrow, I do also want to spend a minute going over the framework for the county's indoor masking plan that describes the varying policies that will be in effect depending whether we are in the CDC designated low, medium, or high community level. This table is really adapted from a table in our updated COVID-19 response plan, which you can find at ph.lacounty.gov/COVID response plan. As you can see on this slide, this framework also varies the guidance by whether the weekly case rate is above or below 100 new cases per 100,000 people. A moment ago, I described the indoor masking policies that will be in effect when we're in a low community level with a weekly case rate below 100. And you can see that on the left side of the table. There's also a couple of other areas worth reviewing. Along the bottom row, you see the indoor masking requirements associated with public transit. When we're in a low or medium community level, the indoor masking guidance on transit will depend on the amount of virus circulating in the community, as measured by the weekly case rate. If the case rate is below 100, as it is now, indoor masking will be strongly recommended. If the weekly case rate moves back above 100 for 14 consecutive days, universal indoor masking on public transit will be reinstated. A recent study on the impact of the pandemic on public transit workers in California found that from the start of the pandemic through May of 2022, outbreaks were 5 times more frequent and mortality almost 2 times higher among workers in bus and urban transit industries when compared to all other industries. We cannot just ignore the higher risk associated with public transit, especially for transit workers. If case rates rise to indicate high transmission, layering in more protection to prevent spread is appropriate. I also want to draw your attention to the far right side of the table and talk about, wait, we're on the wrong table.
Sorry.
No, go back. Go back. Yeah, sorry. The right side of the table, and I'm going to talk about what's required if we're designated at the CDC high community level. In this situation, should both hospital metrics, exceed the threshold of 10, that is that the hospital admission rate is above 10, and the proportion of hospital beds occupied by COVID patients is greater than 10%, universal indoor masking at public places would be reinstated. CDC's community level metric was developed earlier this year in the wake of the huge winter Omicron surge. We look back at how the CDC community levels would have reflected risk in LA County if this framework had been used earlier in the pandemic. What we found was that both hospital metrics rose above 10 before each of our 2 major winter surges, when risk was rapidly increasing. Clearly, if we found ourselves in a similar situation in the future, where we'd be headed for another devastating surge, indoor masking would be an urgent public health measure for all of us to follow to counter the exponential viral spread. Of note, in this most recent summer surge, the percentage of inpatient beds occupied by COVID patients never rose above 10%. Next slide. I also want to, as always, provide an update on the COVID-19 early alert signals for LA County. In the past week, there have been further decreases in 4 out of 8 early alert signals. Decreases were seen in the percent of emergency department visits that are COVID related. We moved from 5% to 4%. Decreases were also seen in the weekly case rate in the lowest income areas, where it decreased from 91 to 80 new cases per 100,000 people. There was a decrease in new outbreaks in TK through grade 12 school classrooms from 15 to 12. And the number of new worksite clusters reported per week declined from 71 to 68. There were slight increases in 2 early alert signals. The number of new outbreaks in skilled nursing facilities in the past 7 days went up from 10 to 13, and the number of new outbreaks reported per week in settings for people experiencing homelessness increased slightly from 1 to 3. There's no change in the percent of specimens sequenced that are identified as BA.4.6. This held steady at about 3%, but I will talk about variance in a couple of minutes. And our wastewater metric, although it's pending this week, because we're making refinements to the calculations to produce more stable results, I'm going to go ahead and just share the graphs with you on this next slide. So as you can see, these are the trends that we're seeing in viral concentration for the 4 wastewater treatment plants where we're measuring the concentration of the COVID virus. As usual, we look at the 10-day rolling average for viral concentrations at all 4 of the treatment plants. The white trend line in each graph shows that 10-day rolling average between late July and mid-September. As a reminder, the Hyperion Water Reclamation Plant serves the central and western portions of the county, and the Joint Water Pollution Control Plant serves the southern and eastern portions of the county. These are shown along the top row, and together these 2 plants serve about 7.5 million people in LA County. You can see that at both of these large facilities, average viral concentrations in wastewater plateaued the past couple of weeks. Viral concentration trends in wastewater for the 2 smaller plants are shown along the bottom. The Lancaster Water Reclamation Plant serves people in Lancaster and Palmdale. And you can see that at the very beginning of September, there was a decline in viral concentration, but since then there have been increases. Viral concentrations at the Tapia Water Reclamation Plant facility, run by the Las Virgenes Municipal Water District and serving people in Calabasas and surrounding areas, continue to plateau. We're starting to see that the trends in wastewater data no longer closely align with our trends in the case data. On the first slide we showed today, we saw continued declines in reported cases, but the wastewater data is showing a plateauing, or even in one community, an increasing of the viral concentration levels. This likely reflects the growing number of people using home tests, the results of which are not included in our case counts. So wastewater data becomes key to understanding the level of viral circulation in our county, given these changes in testing practices. The fact that we're no longer seeing decreases in wastewater data is a reminder that transmission remains substantial across the county, and sensible precautions will help reduce risk. Next slide. The Omicron variant continues, as you can see, to account for 100% of sequence specimens. The BA.5 subvariant of Omicron, that's shown by that larger bright red section at the top of each bar, those are the predominant subvariant. In the week that ended September 3rd, 93% of all sequence specimens were BA.5. This is about the same as it was the week before. CDC is estimating that across the country, as of the week that ended September 17th, BA.5 accounted for 85% of specimens. They also estimate that this subvariant probably peaked at the end of August or beginning of September, when it accounted for 87% of specimens. The relative proportions of other key sublineages we're tracking have changed only slightly in LA County. That includes BA.2.12.1. You can see that with the orange bars, which now decline to well under 1%, and BA.4.6, which you can see with the yellow bars, which is just over 3%. CDC is estimating that nationwide BA.4.6 accounts for about 10% of sequence specimens as of the week ending September 17th. To date, 20 specimens of BA.2.75 have been detected, with about 1% of sequence specimens testing positive for this sublineage in the most recently available data. This week, as you can see on here, kind of, or not actually, because it's so small, we are going to track BF.7. This subvariant is actually a sublineage of BA.5, so sometimes you'll hear it referred to as BA.5.2.1.7. CDC began tracking BF.7 recently, and so we're going to do so as well, but we've only had one BF.7 sequence specimen in LA County. It was collected back the first week in August, and since then we've had no additional cases. But since BF.7 is a sublineage of BA.5, it is expected that the new fall bivalent booster, which provides protection against both BA.4 and BA.5, will provide protection against BF.7 as well. So far, nothing circulating in great numbers that we don't have a bivalent booster ready to provide protection for. Will I go to the next slide? I have some interesting data I wanted to share today from the LA Pandemic Surveillance Cohort study. This study, as I noted, is led by USC's Pandemic Research Center in collaboration with the LA County Department of Public Health. One goal of this study has been to survey residents' behaviors and opinions related to the pandemic over time, with 3 waves of surveying. The first during the spring of 2021, the second wave was the summer of 2021, and then more recently for the summer of 2022. The survey was carefully planned to be as representative as possible of LA County adult residents. Adults were recruited from a database of a marketing research firm which contained about 2.5 million LA County residents. People in the database were then chosen at random and contacted by phone calls and emails with an invitation to participate in this cohort study over time. Enrollment goals were set to match the age, gender, income, and racial and ethnic distribution of LA County adult residents. I'm going to share a few findings from this study, primarily focused on Wave 3, which was administered between May and August of 2022. As you can see, this slide describes the race and ethnicity and vaccination status of survey respondents in Wave 3 compared to adults in LA County as a whole. The race and ethnicity of survey respondents is shown on the left by those orange bars. 39% of respondents were white, 33% were Latinx, 17% were Asian, and 10% were Black. When you compare that to the proportions for each race and ethnicity group in LA County adults, you can see that the survey had an overrepresentation of white residents and an underrepresentation of Latinx residents. You also can see that the proportions of Asian and Black adults in the study were similar to that in the LA County population. A total of 94% of survey participants reported being vaccinated at least with 1 dose of the vaccine. This is just slightly higher than the 89% of adults in LA County who have received at least 1 vaccine dose. Next slide. One of the most helpful aspects of this survey, as I noted, is that it asked some of the same questions more than once, allowing us to see changes over time. Respondents were asked about actions they had taken in the previous week to reduce their risk of exposure. In the spring of 2021, 97% had worn a face mask in the presence of others. By the summer of 2021, the proportion declined a little to 89%. During both those time periods, there was a health officer order that required indoor masking. By the summer of 2022, when masking was strongly recommended and not required except at high-risk settings, the percent dropped to 73%. What I think is worth noting is that while there was a decline in mask use in this past summer of 2022, for almost 75% of residents, masking around others continues to be an important tool in their effort to reduce risk. I'll take the next slide. This slide gives us a bit more information about recent behaviors and opinions on masking. In the question on the left, when asked whether people who are fully vaccinated and boosted should still wear a face mask when they're in crowded indoor settings, 64% of respondents either agreed or strongly agreed. In the middle question, when asked for their opinion on the statement, even if a person is fully vaccinated and boosted, wearing a medical surgical grade mask when in public reduces the chances of getting COVID infection, 85% answered that they either agree or strongly agree. And the question on the right, when asked, when you leave your home, how often do you wear a face mask? 77% answered sometimes, often, or always. Taken together, these responses provide us with an indication that for most people in our county, contrary to what is sometimes portrayed as a complete disregard for public health guidance, masking remains a key part of their efforts to counter the impact of this pandemic. Next slide. For the third wave of this study, we were able to learn more about recent behaviors and opinions on isolation and quarantine. In the question on the left, when asked whether people who test positive for COVID should remain at home for at least 5 days, even if they don't have any symptoms, 92% answered that they either agreed or strongly agreed. And on the right, people who have been exposed to someone with COVID were asked, Once you found out you were in close contact with someone while they had COVID infection, did you quarantine yourself according to the public health guidelines that were in place at the time? 81% replied yes, that they had followed the requirements. Taken together, these results also indicate that the vast majority of residents are likely to take appropriate actions to reduce the risk to others after a positive COVID test or exposure to someone with COVID. Next slide. Before closing, I just wanted to quickly highlight that we may have a new bivalent booster available for children, bivalent boosters available for children this fall, perhaps as soon as mid-October. These vaccines would provide protection against BA.4 and BA.5, just as they do already for adults. Pfizer's bivalent booster would be for children ages 5 to 11, and Moderna's would be for children ages 6 to 17. If the bivalent boosters for children receive authorization and are recommended by CDC, it's anticipated that they'd be available only as a single booster dose for those that already received their primary series. Most likely, this bivalent booster would replace other pediatric booster vaccines, as was the case with the new adult bivalent boosters. LA County is preparing now to be ready to order doses when they're available, and then to be ready to administer them once they receive their authorization from the FDA and a recommendation from CDC. I will, of course, give you an update as soon as we have more information. In closing, last week we talked about how getting vaccinated is part of getting ready for the fall and the winter. We're fortunate to have the new bivalent boosters for adults widely available already, with the possibility, as I noted, of bivalent boosters for children very soon. The bivalent boosters provide protection against the subvariants that are currently circulating at the highest levels, and they're going to be one of our best tools in planning for a safe, healthier, and happier fall and winter holiday season. And now I'm going to turn it over to Dr. Singhal, the Chief Medical Director for the LA County Department of Public Health, who will give the update on monkeypox. And of course, after that, we're going to be happy to take your questions.
Thank you so much, Dr. Frere. Good afternoon. I'm happy to be here to provide a brief update on the ongoing monkeypox outbreak in Los Angeles County. I'll present a situational update, some case data and trends, and share our latest vaccination administration data and a map showing our vaccination sites throughout the county. I'll take the first slide, please. So worldwide, the number of monkeypox cases now exceeds 64,000 across over 100 countries. With over 24,000 confirmed cases, the United States is reporting the largest number of cases of any country worldwide, and California continues to account for the largest number of cases in the U.S., with 4,753 cases. Here in LA County, we surpassed 2,000 total cases of monkeypox this week. As of today, we have 1,937 cases in LA County, in addition to the 106 cases reported in Long Beach and 27 cases reported in Pasadena. The cases in LA County continue to align with the profile of cases seen nationally and internationally. The median age of monkeypox cases remains at 35 years. 97% of monkeypox cases report being male. 94% of cases where sexual orientation is known report being LGBTQ+. In Los Angeles County, 84 persons with monkeypox, or 4% of cases, have been hospitalized. Next slide, please. Here you see the latest epidemiological, or EPI curve, for monkeypox cases by episode date, which is when the case reports symptom onset. The methodology has been updated to align with CDC's, and it now shows daily case numbers in the blue bars rather than weekly case numbers shown in the past. In addition, the dark pink trend line shows the 7-day average cases. As a reminder, due to the time lag between symptom onset and cases being diagnosed and reported to the Public Health Department, data for recent weeks are incomplete. Thus, today I'll focus on cases with episode dates from the start of the outbreak through 2 weeks ago. What is apparent from the curve is that there is a fairly clear downward trend in cases starting the week ending August 25th. Specifically, the 7-day average of daily cases declined from about 40 daily cases at its peak on August 20th to 15 daily cases on September 8th. We are hopeful that this decline represents ongoing slowing of monkeypox transmission and a decrease in the growth of the monkeypox outbreak in LA County. Next slide, please. This slide, which shows proportion of monkeypox cases and case rates by race, ethnicity, healthy places index quartile, and service planning area, helps us to understand the impact of monkeypox on different communities in Los Angeles County. As you can see, Latinx residents continue to account for the largest proportion of our monkeypox cases, with 44% of all cases. Count for population sizes, Black or African American residents have the highest rate of infection at 29 cases per 100,000 population, which is a slight increase from the case rate of 26 cases per 100,000 reported last week. They continue to be followed by white and Latinx residents with 18 cases and 17 cases per 100,000 residents respectively. Our least healthy communities are also disproportionately impacted by monkeypox, with 42% of all monkeypox cases in LA County reported in Healthy Places Index or HPI quartile 1. These are considered the least healthy communities in LA County based on 25 community characteristics, including access to healthcare, housing, and education. These communities also had the highest rate of infection, with 25 cases per 100,000 residents versus 15 to 18 cases per 100,000 for HPI quartiles 2, 3, and 4. Regarding the geographic distribution of monkeypox cases, Service Planning Area 4, or our Metro SPA, continues to have the largest proportion of cases and the highest monkeypox case rate, which increased over the past week from 63 cases per 100,000 population to 67 cases per 100,000. Although SPA 2, which includes the Santa Clarita and San Fernando valleys, accounts for a larger proportion of cases, SPA 6, covering South LA, continues to have the second highest rate at 18 cases per 100,000. We are working to address these regional differences and disparities among persons of color and those living in our least healthy communities through collaboration with our community-based partners, tailoring messaging, and improved access to vaccines and TPOXX treatment in our most impacted communities. Next slide, please. Vaccination continues to be a critical part of our monkeypox control efforts. After receiving tranche 2 of phase 4 of our vaccine distribution last week, we now have received about 65,000 total vials of the Jynneos vaccine. The first 43,290 were single-dose vials received in earlier phases of allocations, and the remaining 22,294 vials from recent allocations are multi-dose vials based on the alternate dosing regimen. We estimate that the vials received to date equate to about 154,000 doses. As of yesterday, 49,222 vials and 84,875 doses of Jynneos vaccine had been administered. This represents 75% of total vials received and 55% of total doses received. Of doses administered, approximately 76% are first doses and about 24% are second doses. We continue to strongly encourage residents who are due for their second monkeypox dose to get vaccinated now to optimize their immune response. While increasing steadily each week, only 46% of individuals in LA County who are due for a second dose of monkeypox vaccine have received it. Next slide, please. Currently, monkeypox vaccinations are being offered at a variety of sites throughout the county with the goal of making vaccine easily accessible to all persons who are at high risk for monkeypox. Together, our vaccination network has over 100 public and community clinic vaccination sites located throughout the county, including Long Beach and Pasadena. This map includes the 72 vaccination sites that are open to the public for monkeypox vaccinations either by appointment or walk-in. These include our public health centers, public health and community pods, pharmacies, events held in partnership with community-based organizations, pop-up events, and community clinics that are offering vaccines to the general public. In addition to the 72 public vaccination sites, it shows the 36 community clinic and hospital partners that are offering monkeypox vaccinations to their eligible patients. These providers have been critical in reaching the populations most at risk in their medical home. We are encouraging eligible residents to either walk up to a public vaccination site or make an appointment at myturn.ca.gov to be vaccinated. A list of vaccination sites, including sites that are offering walk-up, is posted on the Public Health Monkeypox webpage. And as I previously announced, minors between the ages of 12 and 17 years can receive the monkeypox vaccine without parental consent at public health clinics and pods. Minors 6 months to 12 years of age require parental consent and must be accompanied by a parent, legal guardian, or responsible adult. Consent forms and further details are available on our website. Minors who plan to be vaccinated at a site other than a public health site should contact the vaccine provider to learn about requirements for parental consent, as they may differ across the county by healthcare provider. This concludes my remarks. Thank you.
Go ahead and start facilitating questions. If anybody has a question.
Hey, Dr. Ferrer, what's the main difference between the California mandate of mascarillas and the LA mandate? And if please you could also answer in Spanish, I'm with Univision.
Okay, no hay mucha diferencia en las mascarillas por ahora, en este momento. Porque aquí en el condado también podemos quitar las mascarillas, así es el deseo personal, a no tener las mascarillas. La diferencia será si en el futuro tenemos muchos más casos de COVID. Si vamos a subir en el número de la gente que tienen COVID, es posible que vamos a tener que todo el mundo poner las mascarillas de nuevo. Eso sí es la diferencia por ahora que tenemos con lo que ayer salió en el estado y lo que tenemos aquí para el condado. Es verdaderamente para el futuro.
Thank you.
Okay, no hay de qué.
Marlo?
Hi, Dr. Ferrer. Hi, Dr. Singal. Thanks so much for the time today, and in person 2 times in 3 weeks. We really appreciate it. Okay, so given that the California Department of Public Health announcing that it's easing its general masking guidance, in addition to that, earlier this week, it took effect last Saturday, that it dropped its weekly testing for unvaccinated workers at high-risk settings like hospitals and like schools. Isn't it now the time, why not give that decision-making power to school districts and to parents on the best way to handle the COVID-19 exposure?
Yeah, thanks so much, Marla. I appreciate the question. You know, our teams looked at the data, looked at the recommendations from the state and from CDC. We remain convinced that those recommendations don't say it's individual preference. They actually say it's strongly recommended that people go ahead and, in fact, if they're not going to be able to stay home after they've had an exposure, that they go ahead and put their mask on when they're around other people. Here in LA County, we want to make sure that people understand that to mean that we need you to actually do that if you're going to be around other people during that exposure period. We do have the most infectious variant circulating right now that we've ever seen. Schools of all places are very familiar with how quickly there can be spread amongst students and staff. So again, we understand that there's a desire to go ahead and make individual choices for everything related to COVID. We would argue that there are some instances where it's really still a very good idea for there to be a standard that we all adhere to, because it's a way of keeping ourselves protected, those most vulnerable protected, and frankly, we think a faster way, hopefully, to reaching a place where this pandemic is no longer such a big threat to those most vulnerable.
If I may quickly follow up, do you have hard data, hard numbers that show that the 10-day close contact mask policy is in fact preventing spread among schools? Can you say how many cases it has prevented among staff and students?
It's a great question. You know, it's sort of the negative impact, right? I mean, it's something you can't really see. You can see when there is spread, but it's very hard to actually see when there's not, and then determine that the reason there's not spread is because people are in fact wearing their masks. What we do know is that in places where not just students, but workers, I want to bring in our work sites, where people are very compliant and in fact keeping on their masks, particularly because we measure this during outbreaks.
But I'm just referring to schools because I know the parents, many of them,
Yeah.
would like that.
Yeah, I think at schools, the data we have is data that shows that we are having decreases in the number of cases and clusters that are identified at schools, and in fact in the number of outbreaks. I would hope that that's in fact in part due to the fact that as there are exposures, people are keeping their masks on so that they can prevent the unintended consequence of spreading to others.
But no hard data in terms of.
I think that's hard data. I mean, that shows us a decline as we continue to go ahead and keep our masks on during that exposure period.
Dr. Farrer, two-part question. When you cited those numbers that LA County still strong mask wearers, how concerned are you that the easing of mask rules will reverse those numbers and become a self-fulfilling prophecy? Part two being, as we enter this stage where people get comfortable with the idea that if the pandemic, if not over, is at least a lot different than it was, that putting the genie back in the bottle, so to speak, might be really difficult in terms of instituting stronger rules back.
Yeah. I think they're both really good questions and really important questions, so thanks for asking them. One of the reasons why we were pleased to be able to share the data from the survey on masking is, I think, contrary to like what, sort of we're all thinking is happening, that data shows that a lot of people are still listening, and even when we were just strongly recommending masking, they're keeping their masks on in a lot of different situations. So I'm hopeful that as we've reached this level where, in fact, we have less spread than we've seen for quite a while, people can feel comfortable making those decisions because there's a lot less transmission without it being as risky as it would be if there was a lot more transmission. But I, like you, worry that in fact, should we go back to a time where transmission rates again climb exponentially, and we need to ask people to go ahead with universal indoor masking so that, because we have so much transmission, for some people that may become a hard decision. I will say we are relieved with the data that we shared today, because we do feel that, I know sometimes, you hear from people, masks don't work, we're not gonna wear them, we never are gonna wear them. But the vast majority of people are wearing them, and I think they're wearing them appropriately. So my hope is we continue to do what people in LA County have been doing for more than 2.5 years, which is assess not only our own individual risk, but the risk of people around us in our workplaces, in our community, when we make the decisions about when it's going to be important to keep our masks on.
Dr.
Thank
Farrer.
you. You gotta meet that one.
Okay. Dr. Farrer, I have a question sent in from Joy Benedict at CBS2.
Yeah.
How many bivalent boosters has the county administered?
That's great.
How does it compare to a year ago? And since many people are already recovered from Omicron, the question I get a lot is, do I still need the new booster?
Yeah. Well, let me start quickly by saying that the way we capture data on bivalent administration as opposed to doses that have been distributed is through my turn, and we don't have the data from the state yet. We've been told that by next week we should be able to present that data, so I apologize, but we just don't have accurate numbers on doses administered yet for the bivalent booster. We do know that unlike in the past when we had a rush at many of our sites, we have not seen that rush, but all of our sites are reporting steady uptake in people coming in for the bivalent. So I don't think there's been a rush. I think in part there's not a rush because of the second question, which is what should people do who are recently infected? Anybody who's been recently infected at the point that they no longer have symptoms and they've recovered is in fact eligible for that bivalent booster. So I don't want anybody to think you have to wait a certain amount of time or a certain number of weeks after you've been infected before you can get the booster. You can get it as soon as you're fully recovered. Generally, we say that because we don't want people who are still sick, testing positive, to come out to a vaccination site to go get that booster, and you want your body to basically be in decent shape. But there is evidence that suggests that people who have been recently infected will have some natural immunity that will boost their system, even if they've been previously vaccinated, for maybe somewhere between 2 to 3 months. So there are lots of folks who will decide for themselves that they want to go ahead and wait a little while after they had that infection. And that also is an individual preference. And people who have concerns because they have underlying health conditions or they're immunocompromised should make that decision with their provider so that they're maximizing their protection.
I'm gonna go back to Marla, and then I'm gonna read some questions from Ron.
Okay.
Were you watching 60 Minutes live on Sunday?
No, I was not.
You certainly then, nonetheless, you still saw President Biden go on national TV
Yes.
and say the pandemic is
I
over.
did.
When you saw that, what was your reaction, and were you concerned at all that that would make your job even harder to justify any COVID-19 mandates?
Yeah, I think it was an unfortunate choice of words. I think the president was really expressing what all of us feel and know, which is we're in such a better place this year than we've ever been in the pandemic. And, even Dr. Tedros at the World Health Organization has indicated, we can kind of see the finish line. But I prefer the way Dr. Tedros talks about it, which is we're getting close, but there's a lot we still need to do to get to the end of the pandemic. So I think we all should keep that in mind. We know because we live with friends and family and we have coworkers. Many people are still getting infected. Some of those people are quite sick. And it's still, for all of us, important to particularly protect the most vulnerable. So, I'm hopeful that most people heard that and understood that it really was meant as, like, we are doing so much better. We're so much better prepared. I will say my fear is always that when you hear that the pandemic is over, we stop getting resources for the things we desperately need to keep each other safe. So we need money for vaccines so that they're still free. We need to have free testing. We need to have free access to the therapeutics in order to get through the next few months. So, my hope is no one thinks that we don't need those resources to continue to do the important work we're doing.
Got several questions from Ron Lynn at LA Times. The first several are regarding your plan to reinstitute a mask mandate should conditions worsen. I wanted to clarify. To get into the high community level category, CDC only requires either the hospital admission rate or the percent of staff inpatient beds occupied by COVID patients to exceed 10 to get into the high category. Is your threshold for a new mask mandate even more difficult, that we have to hit both of those thresholds to go into a mask order? If so, why? And there is a follow-up to that.
Yeah, it's a great question. I tried to make it clear. I apologize if I didn't. But you're right, Ron. We are slightly different in what will trigger universal indoor masking in LA County than what CDC has set up, which is CDC, when a county gets to high, has recommended that there be universal indoor masking. We cannot change when CDC designates us as the high level, and that will only take us meeting a case threshold and the corresponding one of the hospital metrics. But for us to actually go ahead and implement the universal indoor masking in LA County, we'll need to hit the threshold for both hospital metrics. And that's really based because we look back at our data. And it really makes sense when you look at our data that when there was really increased risk, particularly for the healthcare system, it was because both of those metrics were actually over 10. If you remember this past summer, the proportion of COVID patients in our hospitals, inpatient beds, who were positive for COVID never exceeded 10%. But when we were looking at the data for the two surges, the two previous winter surges, we had in fact exceeded that. So we think it's best here in LA County to, again, use our own data to make a slight change to the formula on what would trigger that universal indoor masking.
Then he had a follow-up. If you're concerned there would be widespread opposition to such a masking order and a lot of people ignoring it, given the reaction this summer.
Well, I'm an optimist. You all know me by now. And I think as our data shows, lots of people are still trying to do the right thing. I think everybody is a little bit worried about what's going to happen later this fall and winter. We've experienced sort of two terrible, terrible surges. And I do think that when we're in a situation where there's threats to the healthcare system and we're being surrounded by people getting very sick, because the numbers are just so huge in terms of the numbers of people infected, that you just have more and more people who will end up being really sick. I think people will go ahead and comply with public health. These are sensible public health precautions. Everything we're doing here is really about trying to move us to a place where we acknowledge how important it is to have new tools that help us keep each other safer. Those are vaccinations, boosters, testing, and therapeutics. But when we see things are getting out of hand, we need to go back to the strategies that worked before we had our vaccinations and boosters. If our vaccinations don't work because we have a new variant, or the new variant evades a lot of protections, you're going to want to put your mask back on, because that's going to give you the protection you're going to need to stay safe and keep the people around you safe.
Sorry, I promised Marla the next one, and then we'll.
go ahead.
Okay.
Something in Spanish, because mucha de la gente que utiliza el transporte público son latinos.
Sí,
Ahora que hay un cambio, ¿qué le podemos recomendar?
sí. La recomendación para la gente que están usando tránsito público es que se quedan con las mascarillas. Pero ya no es una regulación, pero sí es lo que nosotros queremos que todo el mundo hace. Todo el mundo debe quedarse con las mascarillas. Si por cualquier razón tú eres una persona que no quieres quedarte con las mascarillas, por favor, si estás usando transporte público, no uses ese transporte si estás enferma.
Thank you.
Okay.
Last question.
Okay. In Ron Lynn's article, actually, most recent, he cited who I believe is your equivalent at the state level, Thomas Aragon, right? California Public Health Director. He said that the changes, given these eased guidelines, will give Californians the information they should consider when deciding when to wear a mask. As acknowledging that it's now gotten to a point where it should just be a choice. Is this frustrating for you to be on the island of your own, knowing that all the other counties around us, and quite frankly in the state, are less strict than you are?
Yeah. I mean, we'll see. I mean, I've obviously had conversations with Dr. Aragon and the team over at CDPH, as well as, our other county directors, health directors, and health officers. We all talk. I think everyone agrees that if things get bad again, there'll be a revisiting of what protections we're going to need to use to keep each other safe. So I know they laid out a hopeful document that we will never have a situation where there's so much risk that the state will think it makes sense to go back and in fact require universal indoor masking. But I think everybody acknowledges that we cannot predict the future, and there may in fact be a time when the state is also going to move in a similar direction as LA County. We've seen that happen before. I think it's a difference in approach. Many of us have lived through cycles where there were public health rules around seatbelts, around tobacco. There was a lot of opposition to those rules. There was some similar questions.
Those are laws, though.
Yeah, those are laws.
Yeah.
But they started with public health actions to try to limit exposures to things that were dangerous and try to come up with rules that would make it easier for everyone to be more compliant with safety measures. So I think at the heart of public health is always going to be this tension between making sure, and we absolutely agree with the state, that everybody has the best information they need to understand the circumstances in which they're living and the kinds of steps that it would make sense to take. But we're also, realistic enough to know that there's always a place for rules to make sure that the collective good is actually able to be realized.
Thank you, everyone.
Thank you. Okay, thanks everyone. It was nice to see you all. Have a great rest of the week.
Thank you.